be here. I'm really grateful for Dr. Nidal and the organizing committee for inviting me here. As I'm seeing, the conference is going very well, very interesting topics, and everyone attending is very much interested, and I think this is how we can progress. The topic of today is about laser rejuvenation. And I think today, many of the people present in this room are a bit confused because of the so many modalities, whether it's laser or non-laser. And within the laser, we have ablative lasers, we have non-ablative lasers, we have fractional lasers, and within the fractional lasers, we have ablative fractional, we have non-ablative fractional. So it's a bit confusing. So the objective of the presentation and the workshop today is to go through many topics which are really important. Hopefully, we'll get out of this room with a better overview about what are we facing, what are we dealing with when we are targeting rejuvenation, what are we going to use and why. So if you look at the motivation of aesthetic procedure, we'll find that the changes happening in the skin along the years are the motives for rejuvenation. If someone is looking like this today, within 30 years, she's going to be looking like this. Those changes are the motives for rejuvenation, which include the signs of aging, like sun and age spots, oculoderma, rosacea, large pores, fine lines, and skin laxity. Those are the changes. Those are the motives which are letting people go and seek the rejuvenation. And keep in mind an important fact, which is the awareness. Today, the awareness of the rejuvenation procedures are becoming much more. Why? There are so many companies all over the world which are making products for rejuvenation, whether it's fillers, botox, chemical peels, lasers, whatever. And those companies are targeting the consumer, targeting the people, so that the general awareness of the procedures which are possible in order to make the skin looking better and younger are very popular now. And that's why today the rejuvenation is becoming an important indication in our daily practice in the field of dermatology. When we look at the issues developed with age, there are some issues which develop early, like the acne scars. Acne scars starting from the 20s, we start to see patients coming to improve their acne scars. Also in the fair skin population, we'll see people coming complaining of lentigens due to the sun damage. And then a little bit after that, in the 30s, we'll start to see cases of rosacea, oculoderma, usually in fair skin population, large pores, fine lines, and then the next stage is going to be the senile lentigens, skin laxity, and nasolabial folds. When we have any of those conditions, it's important to differentiate between the superficially located pathologies and the deeply located pathologies, because each of them will need a different intervention. So localizing the problem is a very important step in the management. It's important always to remember when we are dealing with any pathology, how it develops, and what is the problem which led to that pathology. So for the wrinkles, for example, how does it develop? Over time, collagen and elastin are lost, so the skin gets thinner and has tougher time getting enough moisture to the epidermis. So we start to lose the collagen and elastin, and the skin is becoming drier, so the elasticity is lost. And always keep in mind, regardless anything you will do, that moisture of the skin is very important for elasticity. Do you need a very live example which you will never forget? In children, how do we diagnose dehydration? Exactly. When you touch the skin of the abdomen and it does not retract, it means there is dehydration. This simple test shows how important the moisture is for the skin elasticity. So over time, and we'll demonstrate another reason why we get drier skin with aging, we'll get less elasticity in the skin. At about the same time, the fat in the subcutaneous layer, which is very important to give the skin plump, firm appearance, also begins to disappear. The epidermis begins to sag and wrinkles will form. So always remember, when we have wrinkles, there is loss of elasticity due to the dryness, due to the loss of the collagen and elastin, plus the subcutaneous fat which start to be lost. Now, when we talk about aging, it's important to remember what's happening in our bodies in general while we age. There are two important and major changes happening in the body during the process of aging. Number one, we have reduction in the basic substance of the connective tissue. And that's why when we become older, we are becoming shorter. Why? Because bone is a connective tissue and we get bone resorption, so we get shorter when we become older. Another important thing which is happening during the process of aging is diminished rate of cell proliferation. And the evidence for that is that the wounds in the old age are becoming very slow in healing. While in children, it's a couple of days. The healing is very fast. So those are two important changes happening in our bodies while we age. Now, when we look at the aging of the skin, we have two types of aging. We have what's called chronoaging, and we have what's called photoaging. And those are two different types of aging. And when we have a patient for rejuvenation, it's really crucial and very important to differentiate between photoaging and chronoaging, because both of them will have different changes in the skin which we need to deal with in a separate way. Chronoaging, chrono means time, so it's a reflection of the biological aging. Whereas photoaging is a protective mechanism due to injurious factors coming from outside the body. So if we look at the reflection of the chronoaging on the epidermis and dermis, we'll see biologically we have reduction in the basic substance of the connective tissue. Where is the connective tissue in the skin? Is it in the epidermis or dermis? It is in the dermis. It's the collagen and the elastin. So we'll see that the collagen synthesis is reduced and we have loss of elastic fibers. So this is how the reduction in the basic substance of the connective tissue is reflected on the skin. What about diminished rate of cell proliferation? We'll find that the dermis is becoming thinner because we have less number of living cells, and also the epidermis will show fewer cells and thinner skin. Whereas photoaging, as we said, it is a defensive mechanism. And when someone is attacking you, what do? You protect yourself. The skin protects itself by being thicker. The areas of the skin which are more exposed to the friction is becoming thicker and hyperkeratotic. And that's why we'll see that with the photoaging, the epidermis will show hyperkeratosis, the dermis will be thicker, stretch the blood vessels to bring more nutrition and blood, and inflammatory infiltrate. So this is the picture of the photoaging and chronoaging. When we have a patient like this, we have to say, is this a photoaging or chronoaging? What do you think? This is a severe case of photoaging. We can see the skin is coarse, very hyperkeratotic, and deep, thick lines. What about this patient? Actually, this is the typical way of aging, where the exposed areas of the face are more prone for photoaging, and you can see hyperkeratosis, thick, deep lines, whereas the areas which are more protected from the sun are showing the chronoaging. Okay? So in this case, we have to see what is the full picture, what is the pathology here. This is a 63 years old patient, this is a 49 years old patient, but she has been extensively exposed to the sun since she started to walk till that age, from the sunrise till the sunset. This is what we call the farmer skin. They have severe elastosis. Whereas this is the normal pattern of aging. So in this case, I would like to stimulate the collagen because the collagen is lost. I would like to improve the laxity of the skin. The epidermis is not very much affected. Here, we need to do everything from the top downwards. The epidermis is affected by the photoaging, and the dermis is affected by the chronoaging, which is beneath. So this is how we should look at the skin. Here, this is skin laxity. We have to differentiate between a patient who has skin laxity and the patient who has double chin due to fat, because both of them will need a different way of intervention. So again, diagnosis is very important for the correct management. We have always, as dermatologists, to remember that when dealing with the skin, we are dealing with three distinct layers, which are the epidermis, composed of the stratum corneum and the living cell layer, the dermis, which is composed of the papillary or superficial dermis and the reticular dermis, and also we have the subcutaneous fat. We have to look at each layer and what is the problem in this layer in order to deal with it in a scientific and a good way to get the best outcome. This is one of the most important slides today. we have to remember the structure of the epidermis. We are dermatologists, we are prescribing a lot of topical agents, and sometimes we are very frustrated with the outcome. And then we just think that maybe it's a bad product, let us change it. But we have to remember the structure of the epidermis. Normally, the epidermis should be composed of 65% living cells and 35% corneocytes. With aging, with the different injurious agents the skin is exposed to, this ratio is going to be reversed. So we get only 40% living cells and 60% corneocytes. What is the reflection of that? When we have less living cells in the skin, this means that the nutrition and the metabolism are going to be impaired. The patient is coming to complain that she is not satisfied with her skin. She doesn't feel her skin is healthy. We examine, but there is no pigmentation. There are no wrinkles, there are no pores, but still the skin is looking dull. Why? Because it has less number of living cells. So this is number one. Number two, when we have more cell population of the corneocytes, this is what we call hyperkeratosis, right? The skin is going to be looking like that. There's no single lady who is not using a skincare product, correct? And there's no single dermatologist who is not prescribing a topical agent. When we have a corneocyte epidermis like that, whatever we apply over the surface of the skin will be consumed by the corneocytes, and this is not going to be affected because this is dead cells. And whatever is going to penetrate to the living cells beneath will work on a small population of living cells, so the efficacy is going to be impaired. And that's why in many cases we are not happy with the outcome of the topical agents we have. Someone with melasma or pigmentary disorder, hyperpigmentation, we prescribe hydroquinone for 3 months. The patient will go and come not happy, not satisfied. Sometimes before the lasers we apply the EMLA for 1.5 hours under occlusion. We start the laser and the patient starts